I think we're
Hello,
on.
everyone, and welcome to our webinar this afternoon. This webinar is part one of a three-part webinar series that we are performing on different topics with involved with functional capacity evaluations. So our presenter today is none other than Dr. Joe Castronovo. Joe, I met, it was about 11 years ago, actually. At the time, he was using it, you've used, how many different FCE methodologies have you used?
This is my fourth.
So yeah, he's probably over the last 20 years, how many FCEs would you say you performed? 1,000?
1,500 probably.
Yeah. So just an absolute great opportunity to learn from Joe and from his experience. So today's webinar is going to focus on, supporting validity and sincerity of effort with your objective data, with other things. So I'm going to turn the time over to Joe.
Wow, that was quick. Well, welcome everyone. Let me just get set up with the PowerPoint. Give me 1 second.
Another thing while we're getting set up, with one of the issues with the FCE market, there's all these different methodologies, right? And everyone says, we're the only one that is a valid FCE. And a lot of these different FCE methodologies, what they've done is they've done a study where, let's say there's 20 test subjects, half of them are instructed to perform and give their best full effort. Half of them are giving like sub-maximal effort, and the testers are blind. And then at the end, it'll run through a very specific battery of tests and spit out at the end a validity profile. Is this FCE considered a valid FCE? The problem with that is, for the most part, in, like, for example, return to work scenarios, the primary and main question that referral source is asking for you to answer in performing that FCE is, can this person go back to work and meet the physical tasks, the functional tasks associated with their job? So doing these different methodologies, the Heimerdinger Schattmeyer FC methodology or whatever, there's not really such a thing as like a one size fits all methodology. And doing that's really specific type of methodologies. The issue with that is it completely misses, has no specificity related to that question they're answering, why to do the FCE, which is, can this person go back to work, meet the physical demands of their job? If they can't, what can they do? And so, yeah, that's one of the things that's very different, I guess, with JTEC's approach is we don't have like a JTEC methodology. We leave it up to the evaluators to, whatever methodologies. What I found, my experience in working with lots and lots of very experienced FCE evaluators, is the good ones over time seems like they'll kind of pick and choose from the different models or different methodologies and come up with what works best for them, or even on a patient specific basis, right? So yeah, that's again, Joe will, I'm sure, talk more about that when we get into the presentation.
Okay. Is my PowerPoint showing now?
It is.
All right, I'll start. All right, so yeah, once again, thank you for being here. Happy to be presenting. I've been a long time a proponent of JTEC medical equipment, and like Eric said, I've been doing FCs for 22 years. And we thought this would be a great idea to kind of cover some advanced topics in FCEs. So today we're talking about supporting validity and sincerity of effort. I've worked in, like I said, 22 years. About a year and a half ago, I opened my own company called Functional Capacity Institute, where I do provide FCEs. We do provide patient care. I also do a lot of reviews of other FCEs. So I've seen all types from all markets of what's out there. I also do some education and teaching as well. Sponsored by my MPT Insurance. I'm not familiar, but that was part of JTech. Thank you. I don't know if you want to say anything about that, Eric.
Yeah, so that's dealing with CEU credit approval. And so, after the webinar, we can get you over the information on the CEUs.
Okay. So kind of give you a little bit about my background. I'm in Chicago right now. The tech support's in California, and Eric currently is in Florida. So I think we are coming to you from coast to coast here. Like I said, JTech Medical is a very prominent company in the business. Doesn't tell you how to do things, but just gives you the best tools to perform your FCEs or some of your clinical care. But as a disclaimer, I have no financial interest in JTech Medical and am not an employee of that institution. I'm just a fan of the product and have been using it for the past 11 years, and brought it over to my new company as well. So, but no financial interest in sales there. But so obviously everyone here should have some familiarity with FCEs because we are talking about advanced FCE topics. If you're newer to the game, right? So an FCE is a detailed examination and evaluation that should objectively measure the client's current level of function within the context of their employment. There could be some disability FCEs that also looks at ADLs or leisure activities. It is a measurement of function, are used to make return to work active decisions, disability determinations, or to design your rehabilitation plan. So when I started many years ago, often the FCE was done before work conditioning, so we knew exactly what to work on. I think a lot of physicians now use this to determine permanent restrictions and if they can go back to work. So often it's at the very end, but wherever it might be very state specific that there's a lot of options of what the FCE is used for. So why are you here? Why are you performing FCE? So maybe it's just my boss made me learn how to do FCEs because the clinic needs it. Maybe it's just a new line of revenue for your clinic that you thought this would be a good way to kind of increase referrals and improve some of your revenue for your clinic, which is nothing wrong with that. But after, I think a lot of therapists do this test and they really don't understand the full implications of the test. There could be such an impact on case outcomes when it comes to FCE. So, in Illinois, we have a lot of work comp issues and a lot of businesses leaving, the state because there's high workers' comp cost and a lot of high cost of doing business. So a properly done FCE should, the goal is determine what they can do, a person can do, if they can go back to work, or if they can be on light duty or modified duty. If not going back to their previous job, it's an indication of what type of work they could possibly do in the future. So maybe they can't go back to 100 pounds of heavy demand level, but they can be doing 50 pounds, which is going to make them much more employable. So an FCE can really have an impact of that. Maybe someone who should be working is on permanent disability and enjoying a leisurely lifestyle. And also maybe the employer is not paying directly for the cost of them to stay at home, but it's also affecting their insurance premiums and stuff. And it's putting a big weight on some businesses, and it's not, just not fully their responsibility to get the person for them forever to be just in their home and doing nothing, basically. If you're familiar with like impairment ratings, and that's generally what a physician does, or different depending on what state you're in. Impairments determine how much was a loss of ability or injury to a certain body part of the area. Impairment ratings have nothing to do with function, though. So two people can have the same impairment, but very different functional impact. So if you have a finger injury, amputation, you might have the same impairment with a piano player versus an attorney, but the functional implications is much bigger. So on the piano player, obviously, or we'll say a machinist. So really the only thing out there that's going to determine the person's ability to functionally work is an FCE. So I guess depends on your philosophy, your background. And I think a lot of times therapists and health professionals, are advocates for the patient, which is ideally where you want to be. But I think sometimes you've had this patient and it's maybe your patient, and you've been with this patient for 3 months or 4 months, and they're just saying how hard it's going to be to go back to work, and I'm afraid to hurt myself. And so you're and they kind of even tell you sometimes, I don't want to go back to work. The boss is terrible. It's a terrible job. And you're maybe complicit in their knowingly that they don't really want to go back to work. Maybe you are purposely favoring the patient because your referral source wants you to favor the patient and you want to maintain that referral sources. So, I mean, to be ethical, you want to make sure you do the most unbiased FCE possible. So, and then in your mind, you may think, well, patient can't go back to work, and maybe that's true, but by saying they can't do anything is really a detriment, because not to go on too much on it, but there's extensive research that if someone's got permanent disability, there's lots of problems. There's depression, there's marital issues, there's anxiety, increased morbidities, early death. What percentage of the job market is sedentary and unskilled? So if you have someone who maybe doesn't have a college education, who's done manual labor work his or her entire life, and they were doing 100 pounds and they have a legitimate injury and they're perhaps older now, they can't go back to that job. And if you test them at sedentary or even light, and especially if there's a limitation on the ability to stand or walk, you're basically saying they're always futurely they're unemployable. So only 1% of the job market is both sedentary and unskilled. So again, it's really important that you get these FCs right, and for the sake of the patient and for sake of the industry. FC requirements. So again, a lot of these FCs say, well, the FC was valid, and we'll talk much more about this because this is why we're here today. But do you really understand what that means? If my test is reliable, the patient had consistent effort or high effort behaviors, or is there reliable pain behaviors? Of course, FC always requires thorough documentation and objectivity to these opinions. So what is validity? That term's, again, used all the time. Validity for an FC is the measure of what was intended to be measured, right? The extent of what a measure can be used for judgment. So if you're saying that the FC was a valid measurement, you're saying this is an accurate measurement that can be used to determine future vocational outcomes or possible future medical treatments. Then we go to consistency of effort, right? So was effort and therefore results were consistent throughout the testing, versus sincerity effort, when there was was there a conscious motivation to perform optimally during testing? And there's a distinct, but there's a distinction between those two. Some people will use the term malingering, which is, I kind of take that as there's really nothing wrong at all with the person, but somehow they are making up these symptoms that say they can't work for whatever reason that may be. But more often there's this, what we call with symptom magnification. Yes, this person has an injury. Yes, this person probably has consistent pain, but somehow their symptoms are likely more based on XYZ information, right? Symptom magnification could be intentional, could be for secondary gain. They want a nice settlement. It could be that they are just fearful And they think that if they go back to work, they'll be fired. They think if I go back to work, I'm going to re-injure myself. And maybe it's conscious and maybe this is subconscious. But it's our job as FC providers to kind of determine that sincerity of effort, consistency of effort, and determine that the FC was valid or not valid.
Hey, Joe.
Yes, sir.
Just really quickly on that note, as an evaluator, and it's always that like gray cloud hang overhead. It's the same with any med legal case, right, or scenario where there's that, possibility of getting called into question patient effort. When you do an FCE, they're not looking for you to tell them at the end, this patient was giving like their best effort or a valid effort, or especially if they're not giving their best effort, you're just presenting that data, right? There's no magic battery of tests. At the end of the day, there's nothing you can do to get inside someone's head and definitively say this person is not giving their best effort, right? So your job is just more to present the data and with your observations or whatever to kind of present an overall picture for the referral, right?
I think that's true. Yes. But at the same time, if you have like extensive information that kind of supports that they're not, I mean, it's of course the referral source is final determination, but you're just trying to present a complete picture of that person. Of course, I never say, if I do believe they're giving some maximal effort or failed validity, I'm not saying, I'm not inferring the reasoning why it could.
Yeah,
again,
that's my point is it's really up to the provider then to take that evaluation you performed and make any like determinations based on that exam themselves, right?
Correct. Yeah. So there, like I said, it could be intentional and secondary gain, or it could very well be fear, psychosocial issues. All right. So then often we talk about reliability. So are the results consistent from the same user? So that would be intra-reliability, right? So if I'm doing a test and I'm doing basically the exact same scenario, that my results are going to be consistent on different FCEs. Also talk about, are the results consistent from different users using the same methodology? So I think a lot of these commercial FCE systems out there, they really say how reliable our systems are. But there's really kind of a pendulum of like, the more reliable it is, you kind of lose accuracy, right? Because we're trying to do the same thing, same cookie cutter, same test for every patient out there, where you're not really tailoring it and truly testing the job demand. So the more reliable something is, you're probably losing accuracy and therefore validity of the test. So that's something to always keep in mind. So I think the general census of modern FCE's testing, and this is kind of consistent with APTA best practices, is we want to tailor the FCE to the individual, to their injuries, and to their job demands. So obviously we can't always duplicate everything in a clinic setting, but the more comparable to the job, I think the more accurate and more valid your FC will be. There's also reliability of pain reporting. So again, we can't get in someone's head to say that I don't think their pain is truly a 9 out of 10 or 10 out of 10, but are they consistent? So we'll talk about some things about proving reliability of pain reporting. My 7 out of 10 pain is maybe someone else's 4 out of 10 pain, but again, you can't definitively say that, but we got to look for if they're consistently and reliable in their pain reportings. So how do we find consistency of effort? And there's definitely debate and different research on the topic, but consistency of effort, again, are the results consistent throughout testing? And how do we measure consistency as a clinician? So we'll talk about a bunch. And if you're familiar with JTech, or if you're doing your own system, you're probably familiar with there's consistency on your testing and consistency on repeat trials. There's certain standardized tests for best effort. But there's multiple issues with consistency of effort and being objective about it. Can someone have sub-maximal consistency? And I think absolutely yes, right? So there's a research study of which I cannot find currently, but like repetitive hand gripping, if someone's told to consistently do sub-maximal hand grip, there's a high probability that they can do that. They can consistently do 50% of their maximum if taught to do so, or consciously doing so. So just because you're consistent doesn't mean you're doing your maximum ability. So coefficient of variation, what does that mean, right? So we're consistent on repeat trials, and it is a good measure of consistency of effort. There's could also be your if you're giving your not consistent, just consistent effort, but your conscious effort. Are you doing that consciously or subconsciously? So there's different ways to look at this, but if we're looking at repeat trials and you're not just taking one range of motion measurement and you're doing it 3 times, there should be within, depending what number you use, but 15% to 10%, consistency if you're doing best effort. So if there's a huge range of motion issues or maximum grip, then you can say, well, that person is not consistent on that test. So if you were doing some consistency testing and the person was giving maximum effort, so let's say you're doing the maximum grip test and you did this, 3 times, and then you did some pinch test, and then you did some range of motion, and then you had 10 of these tests and they were all consistent. Well, what does that tell you? Does it tell you that when during the lifting component that they gave their maximum effort? That's absolutely not true, right? All it says is they gave maximum consistent effort on that test, or probably gave consistent effort on those certain tests. So I think the biggest dilemma in FCEs is that there's a lot of providers out there who say, well, yeah, this grip test was consistent, and therefore the FCE is valid. And that is just really a bunch of nonsense, because there's so much more to that. And I think with any internet search or attorneys counseling, that they're told to make sure you do your best effort on these tests, right? And that maybe not necessarily do your best effort on the lifting. So again, coefficient variation measures changes during testing. You're comparing successive trials. Strength test must have less than 50% coefficient of variation. Range of motion generally 10% or less. I think what's great about we stop at this one first, but AMA guides is 3 consecutive trials out of 6. So if you can do it in 3, but if it's not in 3, you can continue on to 6 until you get more consistencies.
Yeah, and Joe, on that note, the AMA, they have, again, very specific criteria for considering a spine range of motion test valid. So they give you up to 6 reps, like Joe mentioned. They just have to be consecutive reps. So it doesn't matter if it's reps 1, 2, 3, 3, 4, 5. They just have to be consecutive reps. And the average of those 3 consecutive reps, it has to fall within 5 degrees or 10% of one another. And so that, when it comes to like CV values, as Joe was mentioning, like, yeah, for a given individual test, it'll give you information on that test. But when you look at things like CV, it's more about interpreting and analyzing your data at the end, like all of it, to give it an overall comprehensive picture of, if 40 tests were performed where a coefficient of variation was generated, 36, met that CV cutoff criteria or whatever, or even, you can look at the data and if the tests that don't meet validity or consistency, they very much so might be, unilateral or associated with the injury, right?
Yes. Thank you. So again, to see coefficient of variation determine consistency of effort or sincerity of effort. Definitely consistency, but there could definitely be some sincerity of effort in there as well. So again, if you look at your typical FCE that I often see, there's these handful of tests, could be 10, maybe it's 20, often less than 20 that are truly objective. And the therapist is saying this person is valid because they were consistent on these tests, and there's really not much more meat to it besides that. Now, if you pull out your college statistics book, there's, statistical significance or their sample size, right? So we all know outliers or there's certain issues that may affect your data, right? So really we need to get a larger sample to determine if someone's doing consistent effort. Does that make sense, right? So again, like if you took example of a vaccine study, we're not going to take a vaccine if there's been 10 or even 100 tests on it. You want to see 10,000 tests to be confident that your answer is answering the question. And again, of course, the more objective, the better. So what I like about the JTEC system is that there's so many more options to do this kind of objective testing, right? So this muscle testing device, which really shows a little bit more than just giving it a manual grade, and it kind of correlates the function in certain situations as well. But you get that coefficient of variation through multiple tests. And then really you look at the finished FCE, you can see over on the bottom, like overall, we had 67 possible tests, not 10, right? Some, I think, often get in the 60s, 70s, or 80s, depending on what kind of testing I'm doing that day. Then you throw in these other tests we'll talk about, and really you're over 100 possible objective testing. So now I'm much more confident saying that this person was giving good effort or fair effort or invalid effort.
And also, Joe, on that note, just interpreting and analyzing that data, you can see that consistently through that battery of muscle tests, there's consistently a bilateral deficit on the right side. I think there's one that is an exception, and you can see the one that's an exception actually has the CV value that's higher at 16%. But even just looking at trends in your data, same thing with like the 5-position grip, you should see those similar deficits, which this would be, obviously a strong piece of evidence or a strong argument that they are giving their best effort, seeing those consistent deficits like on one side, right?
Absolutely, yeah. And I think a little off the topic, but the other great thing about that muscle testing device is, I'm after using it for so many years, you're surprised that like you give this person a 5 out of 5 or a 5- out of 5 of the injured body part. But really there's a stark difference from the opposite side. So now there's a little more cause to say, well, yeah, this person was consistent. There's definitely weakness. Maybe they need work conditioning, or maybe they, that's what it is. And this is why they're going to have some kind of permanent impairment in that shoulder.
Yeah. It's definitely just much more legally defensible having that data than doing the old school, like manual muscle testing, grading at 0 to 5,
Correct. All right. So besides the consistency and repeat trials, there's these classical grip testing that you'll see in most FCE systems. There's a maximum grip test, and there's this pinch strength test, which again is just looking at consistency and repeat trials. We also have that 5-position grip test. Did they have that bell-shaped curve? And the rapid exchange grip, which we'll talk about in a second. The sustained grip is that there's like this consistent fatigue over time. So again, these are objective studies that kind of adds to your volume of objective data that you can kind of support your FCE. So it's not just that hand injuries get all these tests or upper extremity injuries get all these tests, but I do these for all my patients. Everyone grips, everyone pinches, but it's just giving me more objective data to test the person with. So works by Matheson, studies by Matheson, there's no grip strength has no determination of return to work ability. Obviously, if there's a hand injury, we want to know if they can get that grip or how different it is, but there's really no true functional determinant of work just by grip. Again, we're looking at force curves and fatigue and this consistency validity. So if you could just analyze the quality of the curve, you could see that, and obviously this one, but on the true testing, you could see more of a curve, wavy curve or a straight curve on some of these that could kind of add to the consistency. The 5-position grip, like on the map on the right, the classical, very old now research, 40 years old, of the bell-shaped curve. Of course, there can be reasons that's wrong, because maybe someone has an amputation, maybe someone's got a blister on their finger, so maybe that gripping is wrong. And that's a point I forgot to mention before. You're looking at all these tests, and maybe someone did fail a few, and there's a legitimate reason. Maybe they're not paying attention. Maybe there's something physical. So again, you can't put all your eggs in this basket of saying this person's valid or invalid because of this, but we have to again look at everything as a whole. So if you're not familiar with the 5-position grip test, going back, there's the grip dynamometer, 5 positions, 1, 2, 3, 4, 5. Usually it's position 2, sometimes position 3 is the maximum. So if you don't have that bell-shaped curve, that's a sign of submaximal effort. And you could also go back to the rapid exchange test with that as well, which we'll talk about in a second. So the rapid exchange test, if you're familiar with, you're squeezing the grip dynamometer 10 times generally, 5 to 10 times, and for a half second. And if they can't do it properly, if they're over the maximum grip, that's showing a sign that they didn't give their best effort during the maximum grip. So to truly do this test correctly, I'm going to play a video.
Shoulders neutral, elbows flexed 90 degrees, forearms neutral, and wrists between 0 and 30 degrees extension, and between 0 and 15 degrees ulnar deviation. Examiner holds dynamometer and moves it between subject's hands, allowing subject to maintain arm and wrist position. Tell subject, when I place the gauge in your hand, squeeze it as hard as you can. I will then move it to your other hand. Squeeze it again as hard as you can. We will repeat this 10 times. Remember to exert maximum force and alternate your hands as quickly as possible. Then say, "Are you ready? Begin." Place gauge in subject's hand and say quickly, quickly, as you move the gauge back and forth. At least 5 repetitions are required.
So a lot of these tests are not done properly. So if you go back to this, how can you memorize 20 numbers and accurately and write them all down to confirm that this person was consistent with or submaximal compared to their maximum grip? It's very difficult, not impossible. You're estimating. So when you have something like the JTAG dynamometer, where the computer's actually actively capturing the data, I can not worry about it. I can do it at the proper speed, and you can do it at the proper speed, and I'm also observing body mechanics, if the knuckles are like truly gripping, if the muscles are activating. I can see not just with this test, but all the tests, are they giving their maximum effort? So I don't have to worry about memorizing some numbers.
Yeah, Joe, I was just gonna say, like, I don't know honestly how people do the rapid exchange grip test with just a manual dynamometer, because like saying the whole premise or idea for the rapid exchange grip test, it's a follow-up test to usually the max grip test that you have. And the idea is, or whatever the max, whatever rung position had on the 5-position grip had the highest values. And then the REG test, rapid exchange, is a follow-up to that. And the idea is you're passing that gauge very quickly from one hand to the next. So they're not really having a chance to really exert like full force. Whereas in the 5-position grip test, they got a couple seconds to squeeze on it. So what the research shows is that, again, with that rapid exchange, it compares the results to the 5-position, and those values should be lower than the max value on the 5-position grip test. There's some research that shows compensating for like, an adrenaline rush, that validity criteria, that benchmark can be, 105% or whatever the max value was. The main thing though is it's more so like on the rapid exchange, if you're seeing numbers where it's like a 30, 40, 50% increase in grip strength compared to just that static grip strength, obviously there's a mismatch there, right?
Correct. When I first learned in the old days, you'd actually have to have like a tech, and you would shout the numbers out and they would have to write it down. But you're not going fast enough as you should. That was probably not the best way to do it, right?
Reported. Shoulder.
We should get moving. So validity versus consistency. Some examinees are consistent due to symptom magnification, lack of effort, or inconsistent. This demonstrates lack of validity. Others are consistent due to fatigue, increased pain. This may demonstrate consistency with established clinical data. So we must decide whether it is valid based on consistency, based on the known medical condition. So again, someone may start showing inconsistency, especially as the test goes on, and we want to make sure we're not saying they're falsely giving some maximal effort, but that must be documented objectively. Now, the other issue, most of the objective tests out there really have nothing to do with like gross strength, lifting capacity. So I was using the Blankenship system for years. JTech has the dynamic lifting platform with the NIOSH lifting equation, right? Which I've always found it very objective, not determinant of what they can do actively, but a very good predictor model for what they can do. So if you're not using this, this is one more tool in your bag to help determine maximum lifting ability functionally. So instead of just starting with an empty crate or a box, the static lift platform and the isometric lifts gives me a much closer predictor to what they can do. Now, Eric's much more knowledgeable about this as I, and we will also be doing a full another hour webinar in about a month on this topic specifically. So we can just get into the depths of the NIOSH lifting equation and the pros and cons of the static lifting. Now, traditionally, the NIOSH lifting would give you a prediction of 70% max occasional torso lift would be the occasional, and 40% frequent. And I think a lot of people are anti-isometric lifting because it's not functional. You're just lifting, putting force in a finite amount of space, which is absolutely correct.
And that's something that if part of your FCE is making a determination, can this patient go back to work and dynamically lift, say 50 pounds from the floor to waist on an occasional basis? The only way you can make that determination is to load up a box of weights and watch them demonstrate that ability to do that task. But there's certainly a strong applications and use of static strength testing, NIOSH lifts and FCEs. Our software, based on the NIOSH, the results of the NIOSH static strength lift, which NIOSH, again, those lifts are testing for gross strength in specific body postures. And so the data, it gives a percentile rank. It's gender specific. And so, for example, when NIOSH developed these tests, if somebody for their gender and for the given NIOSH test, if they're in the 25th percentile rank or lower, NIOSH considers that that patient be at too high of a risk of injury. And so it's a no-go on any lifting task, regardless of the weight, in that specific body posture. So the predictor will just give you more of an approximation. And again, it should line up with the results of the material handling. There shouldn't be a huge disconnect. There's formulas that our software will extrapolate and then give you, like, if they did 100 pounds on that NIOSH lift, this is generally about what then they should be able to do dynamically on an occasional, frequent, constant basis.
Yes, and after using it for 15 years, I generally find it to be pretty spot on, and it gives me a much, I can really hone in exactly where I want to get that person and if they can go back to work versus just, again, a progressive type of lift. But we don't want to give too much away because we want you back in a month, right? All right, so we're always observing the patient during the FCE, right? So we're observing body language, facial expressions, recruitment of muscle groups during the test to help support full effort. But I want to just highlight, document what you see. I see a lot of FCEs where they just, they click a box saying mechanics changed or pain response seen. Like, that really means nothing in the objective sense. It doesn't really hold up your opinions, because if they call you into a deposition or a court and it could be a year later, you don't know you can't really support that, because to be honest, my mechanics change if I lift my median or 50% of my maximum versus what if I lift my maximum. So we really want to get specific, right? So really document specific changes in muscle recruitment patterns, facial expressions, specifically sweating, shortness of breath, things like this that really can help you support that I believe this is that person's maximum ability. We could also use a series of distraction testing. So again, if based on your physical examination, you're finding that there's a little inconsistency in this or that, and maybe the cervical range of motion or the shoulder range of motion, you're observing what the examiner does when they don't know they are being tested. So pre-test on the spot or pre-planned that kind of distracts that person so they don't know when they're being observed or specifically testing. So it'd be you could have them like turn if they're limited in the cervical motion and they don't know that they're being measured on cervical motion and they turn around, or perhaps you measured your shoulder range of motion, then they wouldn't go beyond the shoulder height. And then when they take off their sweater or they're reaching for a box, that range of motion is much improved. Now, it could be warmed up, it could be a different plane. So again, the more detail, the more you can support that the person was being consistent or perhaps not so consistent. Same idea, blind versus non-blinding testing, but so going back to that NIOSH static strength and lift test, really that the person's not, they don't know how much force they're putting in through that force gauge isometrically. When you load the box up, they don't know what's in that box. And so if they have just an empty box and perhaps they were your work conditioning patient and they know exactly how much weight is in there, they may intentionally or maybe just out of fear that they know that they have not lifted more than 40 pounds. So therefore, I'm not going to be able to lift more than 40 pounds. So there's a little bit of this fear component as well. But the more you can blind test and they've no idea what's in that box, how much weight is being lifted, I think definitely the more accurate you're going to be on your results. I've had many patients who said like, well, what was that, 40 pounds or 50 pounds? And I said, no, that was 70 pounds. And they're just happy to know that they can do that and it didn't bother them. And now they feel more confident in going back to work.
And another aspect of that, Joe, is doing when they're doing, again, the material handling, the dynamic lifting, they're watching you load up like in 10-pound increments, right? So that's the non-blind test.
Correct.
Whereas when you're doing the corresponding NIOSH static strength lift test, that's the blind test. They don't see the results. And our software, again, it'll compare the two where, you know, and again, there's data that you can extrapolate where it should be a pretty close match. If you see those numbers for the NIOSH lift that are just like, I don't know, 200, 300% higher than what they say they can do dynamically. Again, that's kind of another use, and we'll get into that more again in the part 2 of the webinar series.
But I'm also saying there's like a double blind component, because if you're starting with nothing and adding 10, they can count. But if you're actually starting at 30 or 40 and they have no idea what you're starting at,
there's even weights you can purchase, right? That they look like a 10-pound weight.
Yes.
And they're just like no weight. So that, yeah, you can do a lot of different things with like the blind versus non-blind. Even like for postures, for example, you can, you know, ask them how long it took them to drive to the office before the exam or whatever, right?
Correct. And I often just use a box with a lid, so they don't know how much the box weighs. 1, and 2, they don't know how much is in the box when they lift it. But anyways, so again, that whole observation, some call it the kinesiophysical or kinesiophysiological approach. What does this mean is we're documenting biomechanic changes. We're not necessarily taking them to an unsafe body mechanical breakdown, but we want to document to the best of our ability the person's changes that kind of supports that this is their maximum ability, especially if they're doing this over an 8-hour day. You know, could they continue to do that? So again, don't use it generically. You got to be specific on it. Is it objective? Again, I think if you do it well, it's not a pure data number, but if you're really talking about specific changes in muscle recruitment patterns or muscle shaking, there's lots of terms you can use that'll really help support your determination of maximum effort. I already talked about what you need to do. And then I mentioned mechanical changes versus kinesiophysical endpoint. We're not trying to hurt the person. We're just trying to document that this is a challenging thing for them during the lift, or not challenging. Again, going back to the physical examination component of this, there's so much here that, again, supports our determination of sincerity of effort and consistency of effort. So if we're doing upper extremity range of motion or any range of motion or any muscle testing, we're looking at the consistency of effort. There's also a whole bunch of things that a lot of therapists don't do, which would be palpation and sensation testing and neurological signs such as reflexes or vibration sense, that we can really start to see if, especially if you're having like a spinal injury, you're doing the consistency that if they're L4, L5, we want to see a certain, if they have loss of sensation, it should be consistent with that segment of the spine. And if there's weakness, maybe that's consistent with that part of the spine. And if you're familiar, this is all what we call Waddell's testing or non-organic signs. So again, this going back that the physical examination and doing it well is a crucial part of your FCE evaluation. Why is a physical examination important? Besides what I just said, it helps determine that consistency of non-organic signs. But if you could use that, is it consistent with your previous examinations or examinations from other providers? Baseline measurements. So again, if you're comparing, you're comparing that physical examination, if it was consistent with the testing component for such as range of motion or strength testing. As I just mentioned, it's determined for non-organic signs. Is it consistent with the diagnosis of what they're there for? I also think it's very important that you're looking for any contradictions to testing, or that things need to be monitored more closely. So for example, you have that patient who's had multiple injuries and they have a spinal fusion, and you're there for the shoulder that day. If I'm not looking at the whole body and kind of finding out their medical history and testing, that I don't want to hurt them, not knowing that there's a spinal fusion there. So we want to make sure we are clearing that patient and see if there's any other limitations besides what necessarily they're there for. Therefore, I always say that FCE does not include a physical examination jeopardizes a patient's safety. So again, of course, all these measurements of consistency and force gauge and joint mobility, and we can do some special tests of straight leg raise. We can always put this into our special tests that further supports your, validity of effort and sincerity of effort. I'm sure most of you are familiar with the Waddell's signs, but there's also like Corbin's or SARS, which is just a little more of a detailed Waddell's test. There's also modified Corbin's testing, which is for extremities. Is nothing. So you can't necessarily, like, people call it Waddell's. They were negative Waddell's, but they're there for an ankle. Well, that's not even a test for the ankle, so you shouldn't be saying that. So the big picture is you want to findings if it's consistent with the diagnosis. So heart rate monitoring is also commonly used in FCE testing, and I definitely think it's important, not just for safety reasons, but it will tell you something about their consistency of effort and reliability of pain ratings. So heart rate, generally take a resting heart rate. I use, there's monitors now that you can use, of course, the chest monitors, but there's also ones now you just put on your wrist or on your forearm that helps monitor heart rate. Heart rate should be not just measured after each test, because there's a fluctuation throughout the FCE. If you're doing a 4-hour FCE, I often find that if their resting heart rate was 75, they don't necessarily stay at 75, even though they rest in between tests. They're more staying around 88. And now if they're testing during one of the tests was 95, well, 75 to 95 does seem like an extensive difference, but really 88 to 95 is really not much of a change. So really want to monitor before and document before and after each individual test. So again, heart rate can tell us lots of things. It can tell us what kind of physical condition they're in, if they're giving good effort, and if they're consistent with their pain reporting. However, there's no set research that says this change in heart rate determines the maximum effort, or this change in heart rate determines that pain was present. Again, everyone's different. There's lots of components, including comorbidities and physical condition and genetics. What else was I say in that? There's heart rate. So what else should be aware of? Obviously, there's medications that can affect heart rate response, such as beta blockers for hypertension. So if someone really has a low heart rate throughout the test, do they have high blood pressure? Did you take their medication list before? Was it one of those? Because you don't want to say they gave them maximum effort based on a reliable heart rate response without even realizing that they are taking a beta blocker. And I've seen that many times. Going back, so I remember what I was going to say. There's definitely research that shows that heart rate increases with pain. Some therapy systems use a 25% increase, but again, there's no set number. So I think 25% is just arbitrary. There's one research study which says that you have a 8 increase in 8 beats per minute, 6 seconds after the painful stimuli. But this test was done in solidarity. They were just sitting in a chair. They even say, well, the anxiety of being pricked with a pin causes the heart rate, or it wasn't the pain itself. But really, if you're just sitting and you're not, and your heart rate goes up, fine, but there's also more to it because you're actively being tested during an FCE. So you can't just say because their heart rate went up 8 beats per minute that their pain was accurate, because there's so much interplay here. I mean, there is definitely research that says pain may elevate blood pressure, pulse rate due to this, the central nervous system signals and sympathetic response and release of adrenaline. But again, there is nothing definitive saying that this number of heart rate increase is consistent with pain. What I generally do is you look at the person's age, and if you're familiar with 85% of 220 minus their age is what their maximum safe heart rate is, or you could take a range of 60 to 85%, or are they kind of consistently going into that range? You could also use the rate of perceived exertion. So if after especially types of lifting activities or heavy activities. You take their heart rate response digitally, carefully, and they say how not painful, but how difficult that was. And if they were a 13, we should have it between 120 and 140. Correct, Eric? It should be within
Yeah,
a
so it
certain range
should
of that,
be,
yeah.
it should be with every increase in that RPE scale, you should see an increase of heart rate. It should be within plus or minus 15 beats per second. So if it's a 12, it would be between 105 and 135.
Okay, 15, yeah.
Yeah.
So that's a very helpful researched protocol that supports the heart rate. Again, you just kind of look if they're consistently having difficulties. Maybe there's only heart rate only went up with stair climbing, but not with the lift. So we've got to compare it between the test as a whole, and there's no like magic number, but it's also extremely helpful to observe and document for consistency and safety. So pain is replicable, right? Pain replication. There's a test called algometry, which is also part of the JTEC equipment. There's other ways you can do this without that, or you could even do an isometric lift consistently without pain or with pain. But pain is a stimulation to A delta and C fibers, right? So certain amounts of pressure on mechanoreceptors or nociceptors will reproduce the pain. So pain should be replicable. So they're having pain for no reason or pain for doing this thing and then not for this. You got to document that there's inconsistency in that pain reporting. I've seen so many FCEs that were basically saying the person can't do anything, and it was really pretty much on 100% of subjective pain. And that may or may not be true, but if it is true, you better have the documentation to support that pain was overall a factor. So heart rate is one, observations is another. The algometry is another one as well. But there's also a series of questionnaires that I think every FCE provider should be using. Not necessarily the same questionnaires, but there's plenty to choose from that not only should be that are objective, that adds to your validity, but are very specific to function as well as pain. So the pain reporting reliable? Do they have psychosomatic issues with that pain reporting? There's a exaggeration of pain, such as in like the pain. Which one am I thinking of? Like pain the pain disability rating or the Oswestry or something. There's or the McGill that there's actually a psychosomatic issue with that pain reporting is not really consistent. There's looking at the pain drawing is do the symptoms correlate to the injury and diagnosis? And they can identify an abnormal pain questionnaire. And you could kind of, again, put all those together to kind of make a final determination of if that pain is consistent or inconsistent. Again, cross-referencing multiple things that all should be carefully documented. So again, there's a sample of questionnaires. Again, you can use your favorite, but I would just use more than one, and I would use them consistently. I often use the same ones for everyone. And then if there's like one, such as a lower extremity functional scale or upper extremity functional scale, or if they're a back or a neck, I use a separate one just for that patient. You could see on the pain drawing on the right, it's definitely abnormal pain, is just for an example. And then to put it all together, you have a validity profile. You can grade it. You can on a regular 80, 90 ABC kind of thing. But you really, as you can see, there's so much you could put together here: coefficient variation, heart rate, rate of perceived exertion, objective testing, and really objectively is a big package for your FCE and your clinic that you can determine if there's reliability of effort, sincerity of effort, and valid results. I say you need at least 40 of these to make sure you have something substantial. So again, the goal is to determine the client's maximum safe functional ability for work purposes, but also support your FCE objectively, show that the results are reliable and can be used for medical judgment, or in other words, that the results are valid and in some cases invalid. All right, so I think timing wise, that actually was pretty good. We do have plenty of time for some questions. Hopefully, if we could always reach out to us afterwards if you have to get back to the clinic, but
Yep.
could,
And also, we'll email you on the part 2 of the 3-part webinar series. And again, that will be like mid-February. The topic on that one is measuring and performing static strength testing and static versus dynamic testing and the value of that in an FCE. So we'll also be doing a live FCE certification training seminar this spring in Chicago, Illinois. We're still trying to lock down dates, but that will be either in March or early April. So we'll keep you posted on that as well. So do we have any questions that we can take? So Jessica asked if the PowerPoint will be available. Yes, that's something that we can email to all the attendees, right, Joe?
correct, yes.
Any other question? Let's see. And we'll also send out a recording of this this webinar. And that's something like for colleagues, as far as like the CU credits, I think watching the recorded version, they have to then pass like a very simple, like multiple choice quiz at the end, right, Joe?
I wouldn't say it's simple. I'm going to make it really hard.
No, and then yeah, and then we'll be doing part 3 of that 3-part FC webinar series in March as well. So hopefully, yeah, you can join us. Question: is there one piece of equipment I should purchase for FC testing through JTech? What would be your suggestion? So if there was one tool as far as like objective functional measurements that would be the most critical, Joe, would you say it's the force gauge, like for FCs?
I would say the force gauge, and the close second would be the grip dynamometer, possibly the muscle tester, but I would probably say that order. Yeah, force gauge.
Yeah, and the force gauge is something, it's not just the NIOSH lifts. You can do any pushing, pulling tasks. So again, if somebody's job is they got to load up a dolly or a cart or whatever with however much weight in a manufacturing environment and then push that 500-pound dolly from here to A to B, it's not about pushing 500 pounds, right? It's about the amount of force that's needed to be generated by that person in order to do that job. So like with the force gauge, our force gauge, it comes with a bunch of different attachments. One of them, there's like a round disc so you can measure pushing strength. So you could actually go on site and measure the actual amount of force it takes them to like push that cart. Because coming back into the office or clinic and doing an FCE, loading up like a weight sled with the corresponding weight, their job, like it's not going to replicate that. The difference in coefficient of friction on the floor surfaces, right? But with the force gauge, you could go on site actually and measure and quantify exactly what those requirements are. And then in a clinic, that allows you to test specifically to those force requirements to actually do the job.
Any other questions?
Another question: without the JTech grip gauge, would rapid repetitive grip be possible, the rapid exchange grip test, and kind of discuss that. People do sometimes perform it with just, manual gauges or digital gauges. But like Joe was saying, because of the whole purpose of that test is you're the one in control. You're holding the grip gauge and very quickly passing it from one hand to the next. So like Joe was saying, I mean, you could do it and then just shout out numbers real quick to an assistant and write them down. But yeah, there's a lot of actually fairly unique tests you can do with our computerized or our integrated grip gauge. You can also do a sustained grip test. So instead of just measuring max grip, you can actually measure that grip strength over a specific interval of time. So that the applicability for that test, like in an FCE scenario, is, let's say you've got a nurse that's been injured on the job, and one of their job requirements is they have to transfer patients, pick them up, transfer them from like a hospital bed to a gurney or whatever, right? So to do that job, obviously it requires a certain amount of grip strength. But if you just do a max grip, let's say it's 70 pounds of grip strength. If you just do a max grip test and they meet that whatever that grip strength requirement is, and then send them to work, well, if they have to sustain that 70-pound grip force for say 4 seconds, that's that sustained grip test is much more applicable and for like, interference with ADLs or job function. And then that sustained grip test, it'll give you a fatigue percentage. So yeah, there's a lot of different things.
Going back to the 5 position, I mean, besides not doing it at the proper speed, I think it's very difficult to accurately read that dynamometer bouncing around. So, I mean, I guess it depends on who you are, but it would be quite difficult to do that one accurately, at least with a mechanical gauge, in my opinion, after doing it for so many years. But yeah.
Okay. And we had another question. Where can your equipment be purchased? So we will reach out to you if anybody is interested in getting more information, or even having myself. I'm the clinical director for the company. I have a certain area I manage, territory. We have other clinic consultants, but if anybody is interested in learning more about our evaluation systems, or even doing a web demo to see the actual systems, let us know. You can email Holt, who I think is the one who sent out the new registration link, and then we can follow up with you to doing a practice analysis. It would be, looking at whatever opportunities. And our systems are not, well, they are FCE systems. That's one of a multitude of very specific, like clinical applications, or the ways that people will utilize our evaluation systems in a clinic. Very rarely does somebody put our system in their clinic and only use it for FCEs, right? Because sometimes those referrals come in waves, but they're using it on general patient care, on work comp cases, med legal cases, just doing monthly evals to objectively document, establish medical necessity at beginning of care, show the efficacy of care with the re-exams, and a discharge, like show what issues are still left, like after they're at MMI. And those exams are also their specific CPT codes that are designated, that you can bill those regular patient exams every 30 days until they reach MMI. So that's what we do as far as a practice analysis. We find out what kind of cases you're seeing, whether those are FCE cases, personal injury, work comp, Medicare, private insurance, and then we can put together like a proposal practice analysis as far as revenue generated from doing those regular exams or doing FCEs. So yeah, if anybody's interested in doing that, and then doing a web meeting, usually takes about 30 minutes. That practice analysis, like, honestly, it's like a 10-minute call, and it doesn't have to be with the doctor. You can be with the office manager, but whoever has that kind of data as far as your clinic focus, the number and type of cases you're seeing. And yeah, that's another. So somebody mentioned that they use our static strength test for doing pre-employment screenings. So a post-offer or a pre-employment post-offer exam, it's almost like a mini FCE. It's on the front end at the point of hire. And then most work comp accidents, work-related accidents, injuries, they happened within the first 6 months on the job. And so a post-offer is after a conditional offer of employment has been made to a prospective employee, contingent on similar to like passing a background check or drug test. Actually, these employers will hire, usually it's outside clinics, to do a pre-employment post-offer exam to make sure that this new hire can meet the physical demands of their job, and they're not hiring basically their next work comp claim, right? So with that, you're dealing with a different mindset of people very highly motivated to get a job, as opposed to, oh man, do I really have to go back to work? And so you don't have to worry about that, the sincerity of effort or whatever. Again, it's just like almost like a mini FCE. The value of doing those post-offer exams is you're establishing baseline values. So if an injury then does occur on the job, you have those exact benchmarks of where they were when they walked in the door. And so from like a rehab perspective, that employer is not on the hook if they walked in the door and say had a 30% deficit in range of motion or strength. The employer's not on the hook to rehab them back to zero, no deficits, just whatever they came into the door. And it allows, the idea of apportionment to the employers, their responsibilities. And then it also gives you in that scenario those exact benchmarks to compare against if in that case you do end up having to do an FCE on that patient. So a lot of different things. You can also do job site analyses. That's kind of what I was talking about with our force gauge, where you're actually going out to the employer and you're doing an accurate, comprehensive job site analysis of exactly what the physical demands and a lot of other things associated with their job and their work environment. So ideally, if you get into that market, you want to position yourself where you're covering that whole umbrella of services. You want to be able to go in and do a job site analysis, which that's going to allow you to do a much more accurate, reliable, valid post offer. And then on the back end, if you do an FCE, you've got those baseline values then to compare to. And, that's where, again, from a rehab perspective, getting them back there. So
I've used it for that as well.
Yeah, and Joe is also available for consulting services for those of you that are either new to the industrial rehab market or FCEs, or just kind of want to elevate or maybe increase the services that you provide. So he is available for consulting, right, Joe?
Correct.
Yeah. All right. Well, any other questions? Okay, someone just commented, we received many WH and CPM referrals. Tips on encouraging consistent effort. What is WH and CPM?
Work hardening and
Yeah, okay, and then CPM referrals.
I don't know.
I'm not familiar with what that is, CPM referrals, but yeah, we can talk offline. Or at least chronic pain management rehab programs. Yeah, absolutely. And those chronic pain.
So what was Eric? What was the question? It was, well, how do you?
So he was asking for those work hardening and like chronic pain management cases, rehab programs. Any tips on encouraging consistent effort?
Tips on considering consistent effort.
I mean, audio cues, just kind of. Do you recommend that?
Yeah, I mean, of course. I mean, I generally tell it, let's go into the work hardening, and then I know pain management could be a different story, but going to work hardening, people are, especially at the beginning, and just I tell the stories that I've seen so many people who the first week's miserable and the second week gets a little bit better, and by the third week they're so happy to be there that they make a change. So until they actually do that consistent effort, and don't just if you come here and just dog it, that it's not really going to be a benefit. But if you try this consistent effort within your pain tolerance, you're going to see an improvement.
And again, our systems can be used for that, to show them initially, hey, well, if they're getting discouraged, right, in a work hardening program, or seeing the results, and very much so for that chronic pain management market, because there you're dealing with people that are in long-term care that are discouraged. Oh, I'm not getting any better. Where, like, for example, if it's pain, at the onset of care, you can do a battery of those algometry tests, and there's gender specific norms for these specific testing points. There's also clinical cutoff points for most of these algometry tests that will tell you if that pain or pressure stimulus is below what that clinical cutoff value at that testing location, that's considered an abnormal response to that pain or pressure stimulus. And algometry, oddly enough, it's probably the least as well known of our 7 devices we offer, but it's probably the best validated, and the amount of research and establishing those normative data points, as well as those clinical cutoff points. I always tell people with algometry, it's a more objective way of assessing pain, meaning, as you're applying that pressure with our systems, the patient is actually holding a separate little wireless switch, and you're instructing them at the first onset where that pressure becomes painful to click that button. So that clicking that button captures that exact data point. There's no lag in them telling you, okay, it hurts, and then you removing it. But a lot of times in FCEs, that will be the first battery of tests that people will do, is algometry testing, to kind of find out what kind of patient they're dealing with. Are they going to be super hypersensitive to pain? Am I going to have to really be careful on this? Are they more stoic, and it's like like a firefighter that's really wanting to get back? Just giving you a better sense of that person's pain or perception to pain at the beginning of the eval. So
you could also, in terms of motivation to consistently work hard, you can do a muscle testing at the beginning and do an isometric lift, not necessarily the whole thing. And if the person sees a little more objectively that, hey, my strength went up so many pounds, or my lift went up so many pounds, it could definitely be a motivator.
And what we see with groups that are involved with chronic pain management and rehab programs is the patients love it on the patient education side, being able to keep them on their treatment plan and not be discouraged, to have that objective data that shows objectively, well, actually, I'm not feeling better. Well, this is where your pain levels were when you came in, and they've dropped down to here. So we need to keep you on your treatment plan. But it's very, very powerful in those scenarios, because when people are in pain long term, it's, there's so many elements of pain, psychosomatic issues, where they might think in their mind they aren't getting any better, but being able to show them that data really helps motivate them, and also just really helps keep them on their treatment plan. A lot of times in those settings, you might hit a cap, right, for the number of visits you're approved. If you've got this kind of data that shows, yeah, they're still improving, they're not at MMI, a lot of times in those scenarios, clinics will get additional visits approved to continue treating them. So, all right, well, we are out of time, but again, appreciate all of your time. Thank you for joining us.
Thank you, everyone.
We will send out a recording of this and the PowerPoints, and then also information on filing with, your local state board or society for the CEU credits as well.
All right. Have a good day.
All right. Thanks, everybody. Take care.